Now, in the previous lecture, you'll recall how we placed the implant and positioned it very carefully using software to digitally manipulate images and place our implant in the optimal position. Now we have to take this digital information from the virtual environment into the real environment, and we do this by use of a guide. Now, guides are very specific devices which are accurately made to help guide you with your surgery. So what are the main aims of this presentation and guided placement? Well, it's to describe the clinical steps for guided placement of a single implant, define the terminology used, explain the main features of guided placement. Hopefully at the end of this you'll be able to restate the clinical steps, relate the digital plan to actual practice, discuss the importance of adherence to the guidance protocol. It's most important that you follow the guidance protocol. With any procedure, in order to keep it safe and make sure you don't miss out any stages, it's most important to have a checklist to make sure you cover all the eventualities and procedures in order. So first of all, you check the equipment and your guidance table, which we'll look at in a moment. You check the template fit. You follow the prescribed drilling sequence as you've worked out from your initial assessment using your digital planning software, and you insert and position the implant to the correct depth. Now you'll recall we do the planning from two types of file. On the left hand side of the picture you can see the digital DICOM file, which is of the CBCT scan, and on the other side we have the STL file, which is used to manufacture the template and also to help position your implant. This is our patient, a young gentleman with a missing canine tooth, and the space mesiodistally here is slightly larger than we'd expect for a normal canine. Other things to notice is that this patient is a class 3 occlusion, the spacing between the lateral incisor, and also that the lower incisor teeth are very proclined, and this, you remember, made reading the scan in this area a little bit difficult, because when you looked at the scanning view or the OPG view, you weren't able to see the full extent of the entire tooth, crown to root tip, because the tooth was proclined or at an angle. The center lines are coincidence, there's no mandibular deviation, and interestingly, for a class 3 occlusion, this individual does not have a crossbite. If we look on the other side of the mouth, we can see the class 3 telltale sign where the lower canine is actually occluding against the upper lateral incisor rather than totally against the upper canine. And this, of course, is because the prognathic nature of the mandible. Again, we can see the quite large space that we need to fill, but also you can perhaps start to appreciate the slight dip, that buccal dip, where we've lost labial bone. Again, if we look at the intraoral situation, we can see on the area where the canine is missing that we have lost bone labially. Now, the way in which to deal with this is to graft the area possibly, or it might be able to get around this dip by using prosthetic means. Obviously, if you graft the area, you have considerations of what you're going to use to graft it. You also have to consider donor site mobility and the possibility of infection following implant placement. Now, if we look to the other side, distal to the canine, there is a space here called the retropoid space, now, or the anthropoid space. Now this is a space that occurs in some occlusions, and we could, if we want, try to reproduce this anthropoid space here, or we can try to close up the gap completely. This is a scan or the STL file of our lower case, and the thing to look at here is there has been some drag on the impression. Now in this particular situation it's not important because the template is going to be made further forward, but if this area was, let's say, on the lower patient's lower left premolar or lateral incisor, this could affect the fit in this region, and the template has to fit 100% accurately on the model, because this is what's going to be guiding your placement. This shows us what is important about an STL file, in that you can manage it in exactly the same way as you would a model in the real world. And we can see that we can manipulate this, we can look at it from different angles here. I can zoom up on it if I wish, I can slide it around, I can look at it from different angles, and it's really just like having the model in your hand, except you don't have all the storage problems associated with keeping these models. And we can appreciate the dip on the labial surface here and the slight loss of ridge height. So this is what we use. We import this image, this file, into our planning software, and we can use this later on to actually manufacture our template. Now the template will be printed, it won't be actually made on this format, on this digital or on an actual model. It will be printed digitally, and it will never actually see the model at all. So the computer will take the digital information here, and the technician can design the template to fit the digital model completely digitally, never seeing any plaster. So you won't be using things like cold cure acrylic, you'll be actually printing it. Now most important in this operation is your preoperative planning, and we've done this via means of our scans. And if we plan things correctly and we know the stages, we avoid this situation of getting into a panic, especially when we're starting to place implants. So 95% preparation, only 5% perspiration. If you don't plan it, 5% preparation, 95% perspiration. So planning and knowing what you're doing and being familiar with your equipment will really help. So our check equipment. This is the equipment you'll be using, and I'll be taking through the various stages. But one of the first things you can quickly glance at when you look at your equipment is, are all the spaces filled? Do you have all the spoons you need? Are the spoons in increasing size? Are the burrs all properly there? Are you any burrs missing? If you look at this, you can see how there's a gradual increase in the length of the burrs. Remember, just because the burr box says that this is a 13mm drill, for example, doesn't mean to say that when it was packed, the person doing the sterilizing didn't put the long burr in the short burr space. So do make sure that everything looks to be the right length and in the right position before you even start the case. Now, prior to actually starting this procedure on the patient, you give them a Corsadil mouth rinse, ask them to hold it in the area of the surgery for about a minute or so before spitting it out. The nice thing about Corsadil is that the active ingredient chlorhexidine diagluconate acts very rapidly and will kill most bacteria in about 30 seconds, and this effect is active for up to 12 hours. So obviously your surgical procedure is not going to take 12 hours, so it's well worth doing it, and it means that we don't have to perhaps use more antibiotics. And in this case we use azithromycin 500 milligrams, just one tablet prior to surgery, and that's all that we need to do with this procedure. If you can arrange a hygiene visit a week before, that's absolutely marvellous. And also at that visit, that pre-visit, what you should do is take the opportunity, if you can, to try the template in the patient's mouth. And if there's any rock or the template doesn't seem to fit properly, then you must take a new impression and get a new template made. Doesn't mean to say you've got to replan the whole thing again, go back to your CBCT scan. No, the model will just be imported into the software and a new template made for you. Well, you've got this plastic guide when it arrives, and you've got to clean it prior to use, so I would wash it, and then you could place it in some disinfectant. Most surgeries will have chlorhexidine. You can invest in some bethadine if you want, or any other cold sterilizing agent. But what you mustn't do is put it in hot water or a dishwasher or possibly an ultrasonic bath, because these methods can result in deformation of the template. Now, this is our drilling chart, and on the top side here, on the top chart, you'll see the tooth notation, the FDA tooth notation, which is 33, which is the lower left canine. You have the drill length, which is 24 millimeters, so you're going to be using the range 24, and we're going to be using the spoon, the R-type spoon, which is regular. On the bottom we've got our brand of chosen implant, which is an OsteoTie. The model is a Uni-Easy, and the reference code for that is UZ315, diameter 3.75, and the length of the implant is 15. Now, this shouldn't come to any surprise to any of you, because we of course planned this in the previous presentation. We planned to place a 15. So the first thing is we place the guide, and we have to ensure that it's completely stable and down properly. Now, this guide hasn't been attacked by moths and had holes eaten in it. These recesses are to allow the teeth through, so that we can check that the guide is fully down and isn't being held up for any reason. You also have the metal ring, which is to help support the spoon when you place them into the mouth. And here we see the guide positioned in the mouth, and there's certain areas where the teeth are coming through, and we can see that this is down. It is fitting around the teeth here and here, and fitting around the lateral incisor, and also the spoon is fitting snugly and nicely inside the guide. So try all this in before you start. You don't want to be finding, when you've anaesthetized the patient, that you're having problems. So don't even anesthetize the patient, try it all in. Because again, if you have to abandon the procedure and you've anaesthetized the patient, then that's unnecessarily put the patient to inconvenience. You can, if you wish, in certain situations, actually inject solution through the guide and use the guide to actually help you anaesthetize the patient. And sometimes you might find that just local anaesthetic in the region is all that's needed. If you do decide the patient needs greater anaesthesia, then what you do is you do an infiltration buccally and an infiltration lingually. There is no need to use any blocks in this procedure. So you will place 2 mils of local anaesthetic, normally lignocaine and adrenaline 1 in 80,000 if that's available in your region, and the same 2 millimeters of local anaesthetic to the lingual side. Now, this is our kit, and I'm going to take you through the various steps and stages in the use of the kit. So we look at our drilling chart, and we know our drill length, and we know our spoon size and our tooth position. So now we know the length is going to be 24, and that corresponds to a drill length of 24 on our chart. We're going to be using the spoon. We're going to be using the regular spoon, which is that area there. As you can see from the numbering, we have 2mm, 2.85 and 3.25, and they correspond to the drill diameters which are on the right hand side of the box. So you make sure that these are placed in ascending order to match up with the order that's on the side of the box, and make sure your nurses or your assistants follow this arrangement. There's different lengths of drills. We have a 13, a 17, 21 and 24. So all the drills in this place will be 13 millimeters long, 17 millimeters long and so forth. And as you move up the drills, the diameter gets wider and wider, which is why these lines are shown to be diverging away from one another as the diameter of the burrs increases. So we're going to be starting obviously with a 2mm pilot burr, and because we've assessed this case as being a D1 bone, we intend to be going the entire sequence, that is to a 3.25 burr for our 3.75 implant. So we're going to be starting with the regular size spoon. We place the template such, and the nurse or your assistant can help hold the template in position, and you can hold the spoon and obviously the handpiece. And then we are now ready to start placing our starting to drill our osteotomy. We've lifted no flap. You can see the W is showing there. It's not possible to fit the W side in because this recess is not large enough to allow that to go in. So there's a safety feature there. And you position the burr within the guide. Do not start the burr until such time as it is inside the guide. You don't want it running around trying to find the access. So you position it and then you're ready to go. And you can see the irrigation switching in now, and the irrigation runs down the flutes of the burr. And you remember that when we planned this case we were expecting dense bone near the apex, and you can see the surgeon is having to press quite heavily in this area to really make sure that burr goes the whole length. Now he's not drilling down to 24, he's only going 15 millimeters into bone, which is the first part. The rest of this burr is being taken up by the length of the template and the spoon. So if you like, some 9 millimeters or so is in this area here and going through the gum. There's a stop here, so there's no need for any measurements because you're just going to go all the way down until you rest on top of the spoon. And then of course we will be ready for the next stage. Now we've drilled to our 2mm and we put our spoon back. We're now ready to go to the next stage, which is a 2.8 diameter burr. So it's 2.85, and we're going to go regular. And again, it's always best to place the burr within the spoon before you start using it. So it's been placed, it's resting down on the top of the gingiva, and now you can switch on the motor and start to drill. And it will get easier, or it should get easier as you go up the increments, because the drill that does the most work, interestingly enough, is the first pilot burr, the 2mm burr. That's having to remove 2 millimeters of bone. This is 2.8, so we're only talking 0.8 of a millimeter of bone more, and that's split into 0.4, 0.4. So really you're only removing 0.4, 0.4 from either side. So a lot less work is being done by the larger drill, and of course the centre part of the drill probably remains very sharp because it never has to do any work. These, you can see the wide sort of flutes or channels running down the burr, and this allows water to be driven down to the tip of your burr to keep it well cool. Now we've used the first two, we've replaced the spoon back into the box, and we're now going to the last spoon, which is our 325, which is the burr diameter for our 375 implant. So again, we're going to place the template. Now in between drilling, if at all possible, do not remove the template. There's always a possibility that you might not get it in exactly the right place. Maybe there's some swelling occurred or some other such thing that might prevent you from placing it. So if you keep the template in the patient's mouth, it's not particularly large or uncomfortable for the patient, so it's best to leave it in situ. And now you take the next size spoon, and obviously you position that into the patient's template. And now you take the burr, you support the other side with your free hand, position it, you're ready, start the burr going, and straight down, and you make your osteotomy like so, and make sure you see that you've gone the whole length. Don't not go to the whole length of the burr. You can't over drill because the stop will prevent that from happening. Now the implant positioning itself, you take the implant from the box and you start to place it. Now I suggest, although you can do this by driven and powered on a handpiece, I think when you're first starting doing implantology, that's quite dangerous because you lose all tactile sense and feedback, and it's very easy to actually miss the access hole and then the whole thing is ruined. So it's much better, and it doesn't actually add anything to the process whatsoever. And so you can see the things being started now, and the surgeon can drive that back home and turning it round and positioning it down and just letting it find its own way down the osteotomy site. Obviously the template has been removed now to allow him to do this, and he carries on screwing it down. Now you'll notice as he screws it down it becomes less wobbly and more firm. You've got good primary fixation there, and now he is going to remove the carrier that comes in the packaging. The first item was an adapter that's used to carry the implant and start the procedure going. Now obviously we're not going to be leaving our implant head level with the top of the gingiva. We want to drop that head down a little bit. Now the point is, how far do you want to drop it down? Now there is a rule that I use called the 1-2-3 rule, which I'll explain to you on another presentation. But for the moment we're going to place this about 3 millimeters under the gum margin. Now you can work this out again from your scan. There's two lines on the driver itself. The first line works out at about 2 millimeters from the top of the implant to that line, and the next line is at about 3 millimeters from the head of the implant to the top of that line. And what you do is you start to insert that implant. You can see there's a ratchet there. Now this particular ratchet is a combined ratchet and torque wrench. Again, we'll do a separate presentation on the ratchet, because you can use that to ascertain your primary stability should you wish to do some sort of immediate loading. So now you can see it's been screwed right the way down to the second line, which means it's 3 millimeters from the top of the gingiva to the head of the implant. And that depth allows you to develop an emergence profile. And in this case, because we've placed the implant head just a little bit lingually to what we would have liked, we want to have enough vertical height to be able to correct that angulation. So we're now down at the top of that first line on the driver. So now, having taken the implant and placed it in, we now want to do our transfer impression to record the position of the implant so that the laboratory can construct the eventual restoration. Now it is also possible to use scanning bodies and actually do a digital scan and make the whole thing digitally. In this presentation I'm only concentrating on using a transfer impression. This is familiar to many dentists who do implant dentistry, but we use a technique called a lock-in tray technique. So we use this particular component, which is called an quick transfer, and we're going to insert the quick transfer. This is a hollow tube with vents, and the important part of this apparatus is the bit that fits the implant. This engages the hex, and records the spatial position of the hex, and this engages in the top of the implant and locks it via friction into place. These are once only disposable items. So it's been pushed into the top of the implant. You'll notice that the top of the implant, the top of this transfer is quite thin, and that's to enable you to push it through the gingiva without too much trouble. It also makes a nice seal and hopefully prevents any impression material finding its way under the gum. If we look at this, we can see that first of all the top of the transfer is quite high, and if we were to place a tray into this, it might catch on the top and cause us problems. Also, perhaps it's leaning a bit towards the lingual and could catch the lingual flange of the tray and again prevent us from taking a good impression. So we just need to change the orientation and the height of the transfer, and this is quite easily done by just bending it. So we can see here what will happen. The surgeon is just using a bit of force on it to actually bend it and reposition it so that it's handier to take the impression. Now this won't affect the accuracy of the impression in any way, and he's just positioning it so that he can have it lying within the tray. It doesn't have to be vertical at all. So again, you can see he's just placing it and he's bending it, and he can bend it distally, medially, he can bend it anywhere he wants in order to optimize the position within the tray. Now the next point is we have to reduce the height of this component, and because it's hollow you can take some scissors and you can just snip it. The nurse can have the suction tip handy just above it, and as soon as you snip it, it gets sucked away into the suction tip. Here we are at about the right height, at the right angle, and we're now ready to take our impression. And for this you need an impression material that actually sets very accurately and also very, very hard, because if you have a soft impression material that sets in a soft set, then it won't be sufficiently rigid enough to pull the transfer or the quick transfer off of your implant. Position the nozzle of the gun on top of the quick transfer, because you're going to be injecting impression material down through the top of the quick transfer. So it's most important. If you don't position it on top, then the impression material will run around the transfer but not through the transfer. And it's by running the impression material through the transfer that you lock it into the tray, and that improves the accuracy, and that's the way it's been designed to be used. So don't just syringe it around, also inject it through the transfer as well. And we should get a nice impression at the end of that, so we just have a look at that. So here it is being positioned on top of the transfer, and you can see how the material has been injected through the vents. And also make sure to record the contact areas, because when the crown's going to be made, you want to have a good recording of your contact areas on your teeth, which is what's happening here. This material is called monoprin transfer, and it sets very hard. You can also use materials such as Improgum, although they don't come in a handgun. But you can put them into a syringe, and then you can again position the nozzle of the syringe on top of the quick transfer and inject material through. And if you're going to use Improgum, make sure to use the hard set Improgum. Now you can see this is the impression has now been trapped in there. We've got the detail for the contact points. You do not try to reposition this. Should you take this out and the transfer remain on the tooth, then you have to repeat the procedure. You cannot and should not reposition the transfer in the impression, because that will really result in a very inaccurate situation. This is what you have. You have the transfer, you have the taper. Then this taper would have allowed you to push it through the gum quite easily. Finally, we need to place a healing cap, And in this particular situation, we use these healing plugs called transmucosal tissue expanders. Other systems use screw-in titanium components, and these work very well, but unfortunately if they become slightly unscrewed, they can be quite irritating and upsetting to the patient, and as they wobble around on the implant they can cause a lot of soft tissue and possibly hard tissue damage, or even ultimately fracture, leaving components behind in the patient's implant. The nice thing about these is they push into position, and if there's an issue they just drop out, and then the patient can wait till they see you again, and you might have to use a local anaesthetic to re-expose the implant. But again, that's a sort of rather minor consideration to having things loose in the patient's mouth causing damage. Sometimes you need to fit a denture back in, and in order to do that you can actually cut away the plastic. This is better than cutting away at the denture because you could affect the fit of the denture, which again would upset the patient that you've unnecessarily trimmed their denture. So by trimming the abutment there can be no complaints from the patient. And these fit on the end of your driver, and this is the same driver that's used for all the prosthetics in this system, and it's also the same driver that's used for the cover screw. So we only have one driver for the entire system when it comes to prosthetics, and that has been just pushed and placed into position and can be left there now, and the patient goes away. They're just instructed to keep the area clean with their toothbrush. There's nothing else. There's no need for any other antibiotics. You may wish to give them one painkiller, but I wouldn't be expecting even too much pain after this procedure, given how small the incision is to actually place the implant. Now, we'll end up with a transfer analog model, and we're now ready to fit this crown. It's going to be a screw retained crown on our abutment, and you can see we have a locking abutment. We have the same configuration of the hex. This is the area which locks into our implant, and then we start to build our abutment coming up like so. And here is our finished crown, ready to be screwed into place the next time we see the patient. Now, if the patient turns around and says, I really want to have that anthropoid space reproduced, well, that's not an issue. We can easily have enough material to actually reduce the distal if needs be and keep the same shape. Most importantly, when we come to fit this, will be that we must check the occlusion very, very carefully. We don't want undue canine guidance on this, and we also don't want it traumatizing the lateral incisor. So this will be the topic of the third and final presentation in this series on guided placement of a single tooth.